Welcome to the Tarrant County Medical Minute podcast.
All right. Hello, everybody. My name is Dr. Omar Selod. I'll be your host today for the Tarrant County Medical Minute. We're going to talk about diverse physician experiences and the evolving landscape in medicine. Joining me today are two esteemed physicians here in Tarrant County. We have our 2025 Tarrant County Medical Society President, Dr. Fisher-Wikoff. And also joining us is General Surgeon from Texas Health Resources, Dr. Dossa. So thank you all for joining us today and coming on the podcast. Let's start with our president, Dr. How about a little bit of where you went to med school, your residency training? You've been in practice for 17 years?
17 years now.
Family medicine?
Family medicine.
So yeah, just tell us your path to this.
All right, excellent. Well, I went to medical school at Texas Health University's Health Sciences Center in Lubbock, and did my clinical years at their campus site in El Paso. From there, I came back here, since Dallas was my home, to do my family medicine residency at John Peter Smith Hospital. When I graduated, I did a very short stint with Baylor for about a year before going back to JPS as one of their physicians, doing a little bit of everything, ER, covering some of my physician colleagues while they were on paternity leave, and staffing my own clinic in Arlington, and even being a clinical faculty for a while. I did that for about 3 years until I decided to make the big jump to private practice with Texas Healthcare, now Privia Medical Group North Texas. And I've been happily there for the last 12 years.
Excellent. Dr. Dossa?
So I went to medical school in Toledo, Ohio, where I'd previously spent most of my life. I started general surgery residency training in Dayton, Ohio. I took a 2-year break and did research at Children's Los Angeles. Came back, finished my training. My first job happened to be in Corpus Christi, Texas, where I started doing emergency general surgery in acute care. Several years later, I'm here in Fort Worth. I practice at Aris Methodist Fort Worth. I'm doing acute care, so trauma and emergency general surgery. I work with residents. I'm one of the core faculty. So that's kind of been my journey so far.
Okay, so medicine is changing quite a bit. A lot of things have changed since when we did residency. I've been practicing for 24 years now to today. So Truwana, talk to me about maybe some changes you've seen over the past few years in your line of practice. We were talking before we went on air, telemedicine, for example.
Yes.
You still do that? Is it a big part of your practice, your colleagues, things like that?
Well, not so much since COVID. As you know, back in 2020, when we had the pandemic, everybody had to switch to telehealth, who was in the ambulatory setting, because that was really the only way that we could see our patients.
Correct.
Especially if you're not a hospitalist or doing any type of acute care work. As the pandemic settled down, and a lot of the changes with particularly reimbursement for telehealth changed, a lot of my colleagues kind of backed off from telemedicine. Some still do it. I still have it in my practice because I find it very useful for certain things that don't necessarily need for a patient to come in. For example, mental health is a great thing that I can do over telehealth. Some of my obesity medicine that I do, I can also do over telehealth as well. So I still use it as a very valuable tool. Another tool that I use telehealth for is now in the changing landscape from fee-to-service to value-based care. And in particular, having to keep up with certain metrics like post-acute care after hospital visits, where certain metrics means that you have to technically see a patient within 7 days. Some of those patients might not necessarily be able to get to you, for instance, if they had surgery or they're still trying to recuperate.
I've always found that funny, right? Like, it's
Yes.
like they have to see you, follow up with your primary care 7 days afterwards. Here's 7 or 14 days worth of scripts.
Yes.
And I mean, come on, they've been in the hospital for who knows how long, and you really expect them to be able to get to your clinic, which may be jam-packed.
Correct.
And the one day that they can come, maybe they're on dialysis, and that's your opening. So I never thought of that till you said it, but I remember, okay, here's your 14 days of medicine when we were residents. Figure it out after that.
Absolutely. Absolutely.
Yeah.
And now it's because of all of these metrics that came into place now, especially now that we're having to move to a lot of these risk models where, if your patient doesn't perform to this level, or you don't have a certain amount of patients that meet this metric, or if they're going over their certain amount of days, we as physicians, especially in the primary care world, because of these risk models, might get penalized for it.
Yeah.
So it's very important for us to figure out a way of, okay, how can I possibly get this patient in front of me within 7 days when my schedule might be booked for various reasons, or my nurse practitioner might also be booked, and I've got to figure out a way to get this patient back in to see me. Sometimes telehealth is one of the few and best options.
So you talked about, so I personally do not do telehealth because it's really me. I have a hard time. For me, I'm a PM&R physician. I have to be able to check reflex and stuff like that. Like, my physical exam is so vital for what I do. That being said, some of my partners in my practice do telehealth. I think they have a little bit more patience than I do. But you talked about reimbursement. So can you touch on that a little bit? Because I know during COVID, it was like telehealth, it was the way to go. And then I had heard, okay, well, reimbursement may be limited with this or that. Can you touch on that a little bit? Because I do get asked that question. Since I don't do it, I'm not really sure about.
It all depends on the payment model. It also depends on their insurance in particular. Some insurances have been very good and gracious about keeping some of their reimbursements, even after a lot of the telehealth mandates had expired. Some not so much. So it's a matter of one trying to keep up with knowing who can reimburse, who doesn't, who falls into a lot of these value-based care models, which can be full-on capitation, meaning that no matter where your patient are, you're going to get a set amount per patient per month regardless. So it really doesn't matter if you're going to get reimbursed or not, because you're going to get paid the same either way.
In primary care.
In primary care, yes.
Yeah, so that's okay. While we're talking about telehealth, Dr. Dossa, in y'all's practice, do you guys utilize that?
That's a good question. I mean, I would say probably not. I mean, it became handy during COVID, when you would follow up with patient that just had, an appendectomy or a cholecystectomy. You could kind of maybe over the phone or something like that, take care of patients like that. But I just find it hard for new patients and things like that to be able to use telehealth. So I don't believe it'll be, or it is a strong part of surgery.
Yeah. Again, physically.
Yes.
Looking at an incision, or is this an acute abdomen? You got to get it. You need your hands on them immediately.
Absolutely.
Yeah. And now that I think about this, I wasn't thinking about this prior. Is I wonder how much residency training allows for telehealth. Because like when we were doing telehealth, it really did limit my residents training for a little bit, because I didn't have them doing it. I really don't know the answer. Telehealth, I do think is a very valuable part of family medicine. I wonder, do they do that at all in resident clinics? I have no idea. It's just something.
So, you had the cohort of residents who had no choice but to use telehealth during the pandemic to continue to see their patients. I bet you now they're much more inept to use telehealth in the future, Now, whether or not this translates into this new post-pandemic cohort, whether or not the residencies training continue to use some form of telehealth, at least in the primary care world, remains to be seen, and would be a great question for some of our local programs.
How is your compliance rate you find with telehealth? Because like in the office, right? Like a lot of times patients may no show or something like that. Do you see that on the telehealth side? Are they more apt to show and be available for the phone call?
Yes, they're more apt to show as long as on the physician side you're available during their appointment time.
Running on time,
yes,
right?
Yes.
Yeah. Well, I mean, that's a fair complaint from them.
Yes.
Okay. And speaking of other, the evolving landscape, something I see a lot, and you'll see it on TV, is in surgery, all the robotics. Can you touch on that? Like, I mean, a human still driving it, right? So, like sometimes I think it can be misleading to the general public. Like, okay, well, we have a robotic surgery, but no, there's a human behind that. What's the advantage to robotics in surgery today?
Yeah, I think that's a great question. I primarily use robotic surgery in what I do, and so, when I talk about a patient about, okay, I do this gallbladder, but I do use robots, I still insert in there, it is me doing it. It is me controlling the tool, and so the robot, at least in general surgery, to me, it's the evolution of minimally invasive surgery. So laparoscopic surgery, we've added this great tool that just makes us a lot more precise, and that it is aided by a robot. So that the idea that a robot is autonomously making incisions or grabbing tissue without us is we're not there.
Right.
I think there's a certain I think there's an article going around about an automated system that's able to do maybe a gallbladder on cadavers. Fair, but we're just not there yet, at least as of today.
Yeah. It's funny. I was actually having dinner recently with a couple of my residents, and the topic of AI came up. And, the younger generation of physician is well more versed when it comes to technology and all that sort of stuff. And I recently have been trialing an AI dictation system in my office. I am blown away with how incredible it is. I go in, have a conversation with the patient, do the whole history and physical. For me, the most burdensome thing is always documentation, right? Like you go, you talk to the patient, you live this history and physical out, then you have to go back and you have to relive it again. You have to dictate the whole thing again. Now with AI, you just take your laptop or phone in and it does the note for you. And have you guys tried that? I mean, I've been trying it, and I feel like it is going to help us.
So the only thing I was going to say about that, I think number one, I think overall we as physicians, we should try to embrace AI. So one of my partners does have an elective practice, and he's doing using an AI software, and he swears by that, right? So when he walks out, 90% of the note is done, and he just has to sign. There's the same version that's out there now that is in the inpatient setting or in ER, and I've asked to have that available, so I haven't used it yet, but I want to try it. But yeah, I'm very excited about those components. Absolutely.
Yeah, I've heard that a lot of the hospitals are putting it in now, and residents are starting to use them in the hospital. And have you tried it?
Yes, we have an AI scribe in my office, and I would definitely say it's been a game changer in my practice. For the better.
Okay.
Because in primary care, as you know, we have so many administrative and documentation burdens.
My gosh, yes.
Especially for a lot of the telehealth and value-based care that we talked about earlier. But for the fact that I can sit there with my patient, talk about what we need to discuss, kind of cue in some of the HEDIS and other metrics that I can talk naturally without feeling like I'm looking at a checklist down at the patient and looking back
Correct.
up. It's made it seem more humanistic.
Yeah.
Not only for the patient, because I can actually turn and face them and talk to them like a normal human being. And it's also been great for me, as far as burnout and extra workload that I have to do, because that's a lot less time that I'm going to be spending, like you're saying, going back, having to refine the note, check and make sure that all the coding is correct. It's not perfect.
Yeah, you still have to go through it,
You still
but
got to do it, but it's
lessens your
huge
burden.
time. It lessens the burden, and
I've noticed, like, I use it, we're trialing it, and I'm using it more and more, and I have more energy when I go home because I'm just not as the cumbersome note, and even though, you have these dictation softwares and they put them in, but, this is incredible. And, your point's a great one, right? Like, we talk about our relationships with our patients, right? They do not want us sitting on a computer looking down and not paying attention to them. But, I don't take the computer in the room, but, a lot of practices have to, because the documentation is so burdensome for us. If you don't do this, you don't do that, you can't code this, you can't bill this, you mentioned, like, I have to do all these things, like when they come back from the hospital, or we're going to get fined, right? Like, it isn't so much of medicine, we have to do this or we're going to have a reimbursement punishment, and the patient, unfortunately, they don't understand what we're trying to deal with because they're in pain. We have to deal with their problems at hand, which we should. But I mean, this whole technology thing, I think, is going to, and I've heard a lot of physicians worried about it. They're like, oh no, that's going to take my job. No, it's going to help your job. You still need a physician,
And that's why I think you hear a lot of physicians, other groups call it augmented reality, intelligence, because it's just helping us along. It's not going to, it's not trying to reinvent the wheel. It's not trying to replace a human being, because for physicians, because of the way that our profession is built, there's a scientific component of it, and then there's a human component to it.
Correct.
And no matter how much our future robot overlords are going to try to suggest, you cannot take that away from a person in a physician.
AI can't see the patient or examine the patient, right? And that's part of our differential, right? Like, doing the physical exam, seeing the patient and all that. AI, I mean, no, but we're so, I don't, it's funny because, like, in our profession, I do feel like technologically, in many aspects, our profession is behind the curve, and so we need to get on it. Mark Cuban, actually, I was listening to him talking about this. He said that everybody needs to be learning about AI right now in whatever industry you're in.
Well, I mean, you don't necessarily have to use it in all aspects of what you do, right?
Correct.
You really just rather than the kind of fear in the unknown, get to know it. My other experience with it is as a patient, right? I mean, a lot of us have now access to our medical record electronically, so not only you get that great experience of face to face, with your doctor, then you can go in the chart and you see everything that you talked about is in the chart because it captures everything. So, I mean, again, I think we really should learn to be friends with it.
You can do an exam and then you go back to document, and you might forget something because you're seeing the next page. You fall a few patients behind. Yeah. But you're right; it captures everything for you. Yeah. So, and I mean, it gives you the ICD-10 codes. I mean, I'm looking at it, I'm like, wow, I didn't know there was an ICD-10 code for that, but okay, let me add it to my, it's, we have to adapt as physicians,
And I was going to suggest, I can see where it would help with like surgery and specialties, especially as from the patient perspective, is because you're talking directly to your patient, you can really tailor your instructions to them. Correct. It's not like they're getting this, blanket, 10 bullet point after visit summary that every patient gets.
Correct.
That's 5-6 pages long with nothing but hoopla in it.
Yes.
But if you can tailor it down to one page that explains everything in perfect English to a patient at their level, they're more likely to adhere to the instructions, and that could actually lead to better outcomes. So I think it's great.
I'm excited to see where it's going to be at.
Yeah.
You know, I have 2 daughters in medical school right now, and I mean, they may never have to type in a history and physical like we did, you know, like their world may be totally different, you know, who knows?
But it's sort of like as a medical student, I remember still, you know, going to the paper chart and, you know, like putting in orders, having my resident come by and sign it. And but that's essentially gone.
Yeah.
Right.
I mean, they'll have it in the OR room and you'll, you know, live dictate, here's what you're doing, and it'll pick it up. And I mean, one day it's just going to produce your note and you're done.
Okay.
You know, you just review it and sign off on it. And, you know.
Yeah, a lot of exciting things, one of the things you can kind of look at, for example, if you have a camera that's watching things that are happening in the operating room, you could look at efficiency. It could look at, you know, the actual case. Oh, yeah, absolutely. So many things that. Yeah. I mean, we could go on and on. I feel.
Yeah.
With this.
Yeah. Okay, so let's change direction a little bit here and talk about advocacy and the future of medicine. So I want to hear from both of you. What helped, you know, get you involved with Tarrant County Medical Society? How about let's start with that. We'll start with Dr. Truana here.
Oh, well, you know, going probably a few years into my practice, into private practice in particular, I was getting settled, you know, got my feet wet, you know, gotten used to the daily grind of what private practice is like, and I figured there's more to this than that. So I came to my first actually women in medicine meeting. Met a lot of great other colleagues, and they were telling me about the medical society. So I was like, well, let me just keep coming back. And that's just kind of how I got plugged into it. Where I got here from a leadership standpoint is, I said, once you come, you're kind of drawn in. You get to see a lot of the advocacy work that we do, a lot of the community health work that we do, talking to other hospitals and other groups, and you just want to become more part of it. And it was interesting that at the same time that I was getting involved with the medical society, I was getting involved with my specialty group, and in particular the Texas Academy of Family Physicians, going up through their leadership experience program, you know, getting onto their committees, getting involved into the to the Tarrant County Academy positions here, and all the things that I was learning and doing up through that pillar. Brian in particular noticed that I could be a good fit for the Tarrant County Medical Society. So that's how I got plugged in, starting off with as a secretary, and then moving up to vice president, then president-elect, and then here I am.
He was right. You've been a fantastic fit for us. Dr. Dossa, how about your journey to?
Exactly. My journey to essentially sort of organized medicine is a little bit different. In Ohio, I believe the system wasn't as strong as it is as in Texas, like TMA or the medical or the county society here. So my focus, honestly, starting from residency to about 3 or 4 years out, was work. Okay, so I was part of a system that was trying to get a hospital to level 2. That was my life. Level 2 trauma. That was my life, right? So my goals were not really kind of aligned to some of the things that the society did. But my wife got involved with the New Essex Medical Society Alliance when we were in Corpus Christi. That translated to the Tarrant County here when I got here, and I just kept an open mind. Whenever I had free time, I decided to just come to some of the events, and which led to the leadership course that I took with the TMA. And I think where it kind of hit me in terms of how important advocacy is was actually going to the Capitol and on the first Tuesday. And I remember one of the quote unquote assignments was to pick a topic that was important to you and go talk to one of the legislators. And so that's exactly where we were. Don't have to mention the topic, but what the response was inquiry from the legislator. They were like, well, what about this? What about that? And I just kind of clicked for me. These people are they're not clinicians. They don't know what we go through, yet they have to make these decisions that will impact me and all of us. So that kind of helped click how important being part of it, the medical society is. Now, I'm still pretty busy, so it's still hard for me to get away and be part of this. But at least I helped me understand the role this has, in all of our lives as physicians.
Yeah, and I would say to physicians that have been in practice for a few years, I mean, I didn't get involved till many years later.
Yeah.
I mean, sometimes I have some guilt about it. Like, what was I doing? I was building my practice and this and that.
Yeah.
I always hadn't, if I can be honest about myself, probably an excuse. And I think I was a little bit intimidated in all honesty that, I'd look up to these physicians and I'd see, and they were talking this stuff. I was like, man, they are really involved and they know so much about the issues physicians are dealing with. And I'm not as knowledgeable. Yeah. I really can't add anything to it. And it wasn't until, Brian and Catherine really reached out to me, and I was honestly a little hesitant.
Yeah.
And, so that's what I would say to physicians. I mean, you can do it early in practice. That's what's best. And I wish I had, but you can join in anytime. Mm-hmm. And our medical society is so welcoming, and if you come to one of the Wednesday meetings, Dr. Fisher-Wikoff is leading them this year, you will learn what's going on in our, it's very commonplace for people to just complain about problems, right? Yeah. And us physicians do that all the time. Yeah. But we also have to be the solution to our problem. And how do you do that? And I think it starts right here with our medical society. We're very blessed with all of our colleagues that are involved, the leadership with Brian and his team. I mean, we're lucky to be, on this team, honestly. So what are the challenges that you see in family medicine, that the medical society is having to tackle or deal with?
I think it's a lot of things that we've had to battle with, in particular at First Tuesdays at the Capitol. It's always going to be administrative burden. Mm-hmm. It's always also for certain groups, it's going to be scope of practice creeps. Yeah. It's always going to be, insurance denials, prior authorizations. Mm-hmm. Those are always going to be kind of our big button topics. Mm-hmm. But we also have to deal, depending on who you, with research and who you talk to, a possible workforce shortage, mm-hmm. In particular for family medicine in the future, because our reimbursements are not that great.
Especially relative to the amount of work you're asked to do. It's not it's not fair.
It's a lot of work, it's a lot of time. It's led to a huge amount of burnout. It's led to, a lot of my older physician colleagues either retiring. Mm-hmm. Some are even retiring earlier than what they should. You have younger medical students who don't want to go into family medicine or primary care. And then you have some that, within my range that'll do this for 10 years until they figure out, what's their next career move. Mm-hmm. Some people will go into administration early. Some will go into social media. It's a bunch of things that people want to do just to get out of the rat race right now.
Yeah. So Dr. Dossa, from a general surgery perspective, can you touch on maybe some issues that you think the medical society can help with? And also, I know you're training residents. how important you feel like it is for them to get involved at a young age. Yeah. One thing with residents is sometimes they don't feel like they have enough time, but the importance and all that.
Right. No, it's interesting. I, although, you're family medicine and I'm surgery, I still highlight some of the same things. How do you, our workforce problem or burnout problem, right? Can TMA help assist in, lowering the burden of student loans, which might have an impact on the workforce. So I still think, although there is different specialties, we're dealing with the same things. I remember being a resident and feeling like I had no time to do anything else, and so having to the thought of going to an event and things like that, I think seems pretty difficult. But I love my residents, and I do think they should try to come to these events. And one example is, I have 3 that are going to graduate this year. They may end up in private practice as part of the group, but TMA has a lot of resources to help them with that. So, and again, whatever goal you have as a physician, TMA does have an avenue to help you with that through advocacy, through CME, through multiple different avenues. So, but I again, it's just hard to really see that while you're in the midst of residency.
Yeah. So one thing that some of my interns, I'm faculty for Baylor All Saints internship, and got them involved with the meetings, and we did a podcast, and them coming in the meeting opened their eyes. Them doing the podcast further opened their eyes, and then they came to me and said, "Hey, I want to go to Austin on the first Tuesday." And so we reached out to the program coordinator and program director, and those that were on electives were granted time off from the day to go to Austin. And so I think that's where, we need to, as attending physicians, think about this a little bit more. So in 2 years, when legislative session comes again, I think we need to be proactive and talk to the residencies, everybody. Hey, we need these young docs down in Austin. Let's give them an academic day off and get them down there. And the TMA and TCMS will help direct them as they did this year. So
and one of the things that we do at our meetings is, of course, always trying to invite residents to all the meetings on that fourth Wednesday. But another thing that we're also trying to look at is trying to figure out, well, if the residents can't come to us because we know their schedules are very tight and they're in the hospitals, is trying to figure out ways to come to them. So don't be surprised if you see us, in your lounge.
I took Brian to a noon lecture for medicine residents and interns. It was one of the best lectures because Brian's our EVP of the Medical Society, and he knows how to talk to a room. But just the questions that all these, young physicians in training had, and him telling them, look, you're part of the solution. Your question's valid. You're part of the solution. Get involved. You could just see like they were so engaged, because a lot of times at noon when you're a resident, you're in a lecture, you're tired, you want to go to sleep, it's your little, nap time. I mean, we've all been there.
Your pre-call, your post-call.
Yeah, but they were highly engaged. So I know we're running out of time here, and we had a lot of more stuff to talk about, but the conversation's just gone too well. Let's just touch on, one last topic is preventing burnout. You mentioned that, in your field of family medicine, there's a ton of burnout, which I totally agree. What advice do you have for young physicians and even elder physicians, like, how to prevent that?
Well, what I would tell younger physicians is even with the amount of work that we do in family medicine, the work is very important. And so I tell my medical students when they come and round with me, when I see residents, I say, our work is important. So please don't give up on the future of family medicine. Also, first of all, it's like the old adage said, when you're on a plane and the plane loses oxygen, you got to put on your mask before you can take care of others. That is really true. So try to find something that sparks you, something that's that aha moment that gives you that breath of relief, and just try to do it as much as you can. For some people, it's going to the gym. I'm going to be honest with you. I can't get to the gym, so that's not me. When I come home, I gotta feed the hubby, the kids,
Right.
But for me, you just gotta find out, what your love is, what you're passionate about, and just use that as your escape, and not use that time to try to figure out a way to sneak in an extra chart, here and there. For me, it's when everyone goes to bed, I get into my nice little recliner and I read a book. On Sunday mornings, when it's Formula One time, I'm there rooting McLaren. So Piastri and Lando Norris, I'm cheering for them for several hours at a time. Yeah. That is my time, and I make sure to protect it at all costs.
Yeah. How about you, Doc?
I like what you said. I think for me, what it's been over the last couple of years, my thing is actually taking regular tennis lessons. So I'm getting a lot better, which is great. And the only thing I would add is probably just, it's learn to say no sometimes. I mean, it's okay. It's okay not to take that extra shift. It's okay not to, say yes to that, committee offer to go. Although, I mean, again, all of it is important, but I think those are the small things that, add on to the load. And, like I said, it's okay to just kind of protect yourself.
I mean, I think there's maybe some good solutions coming up. Like we talked about AI.
Yeah.
Right. There's some technology that I think is going to help us out and maybe potentially lessen the burden, because the burden's been tremendous on our end. Yeah. And, like I tell my daughters in med school, you have to take care of yourself first, like the oxygen thing on an airplane. Take care of yourself first, because you have to take care of somebody else, right? And they deserve, a healthy physician taking care of them. They need that. My stress relief is golf. I've gotten into hitting golf balls. The problem is when I play golf, I realize I love golf, but golf doesn't seem to love me. And so, it's frustrating too. Sometimes I walk off frustrated, but just getting outside and seeing the sun, right? Like we don't have any outdoors. Everything we work is in a building, in a exam room. And it's just get outside and see the sun. I mean, tennis, pickleball, all these things, just get outside. So, but although we discussed, I still think it's the best profession. We have a bright future. These young students and residents really, I find motivating. Yeah. I mean, they are phenomenal. They are phenomenal. They're going in it for the right reason, and they need mentors like you all to continue helping train them. That's another thing I would say to a lot of our colleagues is like get involved with medical education, because they're going to be taking care of us. So. Yeah.
Can I add just one thing about, we were talking about just being optimistic about the future, telling our colleagues to get involved. Also telling our colleagues who wouldn't think they could get involved, like getting more women. I'm huge on that, and saying, it's okay to step into the room and sit at the board table because there's a place for you. I've talked to other physicians, in particular physicians of color, who said, I'm not sure if I'm ready to belong here. I say, yes, you are. I'm a testament to that. Dr. Dossa is a testament to that. And I think if we can get more diverse people at the table, we can also reach a greater amount of people on our medical society. Yes,
that's a good point, because I've said this before, many years ago when I was a young physician and I looked, I don't know, maybe there was not the diversity that made me feel welcome, even though they were welcoming. I just assumed it's not. But yes, we need more diversity representing everybody. And ultimately we're representing our patients and our colleagues. And so, yes, I would love to see more people get involved. And in fairness, the medical society has open arms for everybody.
Absolutely.
But we also have to walk to that.
Yeah.
And I think you all are good role models to help, open up some more doors here. So, yeah. That's a good positive way to end.
Yay.
Yeah. All right. So thank you all for tuning in. You can hear us on Spotify, Apple, YouTube. We're all over. So please tune in and subscribe. Thanks for joining.